Hello.
Hello.
Hi.
Hi. Hi.
Hello. How's everybody doing?
Good. How are you?
Very good, thank you.
Hello.
Hi.
Hello.
Hello.
Hi, Haley.
Hi, Helly. How are you doing? Good that you can join
Yeah,
us
good.
today. Very good. Nice.
Yeah. Sorry. Who? Are you Komal or?
I'm
I don't know.
Poonam.
Sorry.
I'm Poonam.
Poonam.
Yeah.
Okay.
Cool.
Sorry, I don't know how this works actually. So I'm gonna be quiet today, and Poonam, you'll have to call up Komal again.
Okay. All right. We'll get her in. All right. All right. I'll get her in.
And Nancy, Renuka.
Okay.
Everyone's call has dropped.
Oh. Okay. I'll get them. So we need Komal back. Ah. Hello?
Hello.
Yes.
Hello.
Hi. Hi.
Yeah.
Okay.
Hi.
Hi.
Hello.
Hello.
It's Fiona. Can you hear me?
Yes.
We can. Komal is connected or not?
Yes. Looks like Komal is there. Okay. Few other people have dropped again.
Farah, Nancy, Renuka, NG.
Yes.
I think NG is not there today.
Oh, NG is not there today. Yes, correct.
NG is not there.
So, Farah we are trying to get, right? Farah, and who else is there? Some people have dropped out.
Nancy, Renuka, then Pavanji. Pavanji is free.
Okay. So we are still trying to make a call to Nancy and who else?
Renuka, Pandi.
Yeah. There was one more, right, who joined us in this week. One was Helly and Esther.
Yeah, Esther.
Miss Esther. She's not there today.
Esther.
She's not there.
No, she's not here.
Okay.
Ellie, where's Esther?
Yeah, Esther is not there.
I just asked Esther on WhatsApp.
Okay.
Okay. Leona wants to show video. We don't need video calling.
No, we don't need video calling.
Yes, so I'm just gonna. I want to show a video? No. Just decline it. No, it asked me if you want to access. Sorry, I'm new to this.
Okay.
So my camera is turned off, so I don't know what's happening. No, it asked.
Hi, Leona. How are you doing?
Good, fine. My camera is kind of turned off, so I think should be fine.
Yep.
Yes.
Yep. So on your computer there should be a light. If your camera is on, then the light will glow. If there's no light, then you're safe. Okay. So
Right. Where is last time we had two new people, am I right?
yeah, so we have
I think Shravani is not with us today. One was Shravani.
yeah, and one is Helly. Helly Shah is here, and
Pavandeep.
yeah, Pavandeep is not
I'm
there.
here.
Helly is there. Only out of the new people, it's only Helly who's there.
Yes. Yeah, I'm here. Hey. But we don't have Shravani, we don't have Pavandeep. Where are they? Renuka.
No idea.
Yeah, even Parita. We have two Paritas.
Yeah. One is Parita Jain and one is Parita Jaiswal.
I think they are not online.
Okay. The voice is breaking a bit.
Guys, we all need to mute our mic when we are not talking. So otherwise we'll have echo actually.
Okay.
I think Esther would be joining us right now.
Uh-huh. So Helly was asking previously that she doesn't know how this works. So
Yes.
Helly, every week we'll try to solve some papers. So right now we are doing cardiopulmonary papers. We finished 2015.
Yes.
So what I can do is I can post the answers that we've discussed for that, and you'll have an idea. So now when we are doing when we are doing the topics, it's best that if we find an answer, we need to dig a little bit and find out that what is the source or what is the reference of that answer. So I think
Okay.
I replied to your question, and I told you that there are 2 or 3 books which are the reference books for APC exam.
Yes.
Now, I mean, we need to be finding resources from there. Right? So what we
I have prayer and prasad.
Okay. So what we're doing is, for example, there's a question on asthma, like what is the best medicine used for asthma? Now there are options like a bronchodilator. There's an option like beta agonist, short-term and long-term ones. So which one would be the choice? And all of them are right, but which one would be the most befitting? And the answer, you'll have to give a reference that this is in Prior and Prasad so and so page number. You know, so that
Okay, yeah.
yeah. So that's how we all work.
Okay.
Cool.
Cool.
Cool. So today we have what topic do we have today? Today we have March and June of 2014. So we can,
Actually, that's March and September. It was my mistake. It's actually March and September, not June.
okay.
Sorry,
Fine.
sorry, Parita. Can you all add Esther because she's online and she's telling me on WhatsApp. Please, can you all add me?
Okay, 1 second.
Yeah. Where's Parita Jaiswal?
Parita Jaiswal is not there today. She will join us later.
Oh.
Okay, I think the problem is that I can't add Esther because she's not on my friend list. So, Tulsi, right? Tulsi, can you do it? Is she on your friend list?
I have that. Whom I have to add?
Esther.
I think she's not on my list.
Okay, wait, I'll try to find her and then I'll add her on my
She's in my
friend list.
my friend list. Yeah. So you
Yeah,
try to add her?
yeah. So you look at the plus sign and then you can add her into the conversation.
Yeah.
Jaspreet, are you there?
Yeah, I'm there.
Okay, I didn't get formally introduced to you. we don't know who you are. So can you tell us about yourself?
No worries, I'm hearing you all.
Okay. This is the first time you're joining us, right?
Yeah, I'm first time.
Okay.
This is my first Skype session. Yeah.
So you'll have to tell us about yourself.
I'm Jaspreet. I'm from India,
Uh-huh.
from Punjab, Patiala.
Oh, okay.
Yeah,
Nice.
recently I moved to Sydney. Yeah,
Okay.
from last year,
Uh-huh.
and yeah, I'm just begin my process with APC process
Okay.
within this month also. So just looking forward to give exam in December.
Okay.
Yeah.
But December exam, I don't think you can give now because I think the cutoff date for the deadline and payment was 6th, right?
I did it. Yeah, I did it all. Yeah.
Oh, okay, finished. Okay.
Yeah.
Okay, cool. All right.
Okay,
Awesome.
I joined already the Esther, but I don't know if she on or not.
Doesn't look like. I think her name is Jedi, so I don't think she looks like she's on. She's not picking up. Oh, her call dropped again.
Yeah. You try once again, Henry?
Yeah.
Okay. Yeah, sure. Kelly added Esther.
Okay.
Okay, I already add.
Okay.
You don't have or... Okay. Can you guys see her on your screen or not?
No, I can't see her.
Because I add her already. But she will be in the group. Yeah, I add her in the group actually. Can I do one thing? Can I call again?
Yeah, okay, you can. You can.
I'll do that.
Okay.
Hi. Oh, she's there.
Hello.
No, Leona. This is Leona. Sorry.
Hi. Cool. Smartha, are you there?
Yeah, I'm there. I just kept it on mute.
Okay, I don't know why you're so quiet today.
No, I was...
This is the quiet before the party, you know.
Let me get a party. Hello, guys.
Hi. Hi.
Hi, Esther. Hello. Hi.
Hi.
Everybody. I thought it was tomorrow. I didn't read on Facebook. I was at work. Sorry, but I'm here now.
Okay.
Sorry.
All right. All
When did
right.
you start?
We haven't started yet. We are just getting people to come online.
Ready there? Three. We need to drop energy.
Okay. Yeah, they automatically will keep going. If they're not picking up right, they'll keep dropping off.
Yes. Yeah. Yes. So we are 9 of them today.
What?
We are 9 of them today. We
Okay.
are 9
Right.
today.
Right. Yeah.
Okay. So let's give it chance by chance. Let one person all of us get a chance to speak. Okay. So and all of us get chance even to put the things on the screen, the questions on the screen. So who has done this? Poonam, have you put it?
Yeah, I've already put it.
Question. And Jaspreet, can you just read out the question? First few questions for us. And the question paper is on our Facebook, right? On the page? Esther, yeah, it's on Facebook and right now she's posting also. Alright, I was just going to put you and say that everyone will get a chance to post, so maybe I'll just have the papers already. Okay, great. Cut your questions document, right?
Yes.
Yes, start your questions March and September 2014. Alright. This time's recall is really bad, no? Yes, terribly bad.
Did you have a chance to look at the recalls?
No, it said connecting and it just didn't connect in the end.
Oh.
It didn't go through at all, but on the APC website, that guy Dave, he put in questions. Yes.
Oh, okay. All right.
He's not put it in a word form, he just put it in like the normal discussion. Yeah. So I read it.
Oh.
Like a commenting section, yeah. And he has just given the conditions, not the appropriate question or anything, but just vaguely has discussed few conditions.
I see. Okay. I'll take a look at it.
Okay, guys, can we start? Jaspreet, are you reading it, or should any one of us take over? Hello.
Hello, Jaspreet. You can go ahead and read it.
Yeah.
The question which we are posting, so you'll read and then we all will put the answers, what we have thought from our side.
All right.
So I've posted the first case on the right side. If you look at the screen, so on the Skype chat, I've posted the question.
I'm looking forward to it. Just wait a minute.
Okay.
Do you guys want me to read the first few so that she just gets the hang of it?
Yeah, maybe. I think that could be a good idea.
I'll do it.
Yeah.
Hello. So, case 1.
Yeah.
Mr. A is an 80-year-old, almost retired man of a farm who helps his family with the family business. He has had CAPG twice in 1994 and 2007. He lives 300 kilometers from the rehab center. Over the past 4 months, he has been feeling breathless over small activities. He can walk 200 meters on flat ground, but he is very breathless on slope or incline and while climbing stairs. His wife is concerned that he might do too much. What is the best management plan for this patient? First, arrange an outpatient service for his cardiac rehab. Second, arrange a 4-week inpatient stay and then outpatient rehab twice a week. Provide a home program with written exercises and review him on intervals. And last one is review every 6 weeks. Okay, Esther, how come B? Okay. Well, I was thinking, okay, right, let me see. Right, arrange a 4 weeks inpatient stay, then outpatient rehab. Well, maybe no, I'm changing to 3, sorry. Because the thing is, I thought he cannot be coming all the time because it's 300 kilometers away. Yes. So that one can work. So probably, and the outpatients twice a week is not possible. So that's why I would change to 3. Sorry, 3.
Okay. Yeah, so I also thought it's a B because why did I think B? Because in one of the discussions with the moderators, somebody had, somebody had got this answer as B from one of the moderators. So that's why I thought I'll put a B and we can discuss about it. Because
guys, the answer of this question is on heartfoundation.org.au. Okay, I'm trying to find, but I don't know. But it's when we were discussing the APTA sessions. People said that it's on this website, the Heart Foundation, and the correct answer is 3 because the patient stays, Mr. A stays 300 kilometers, and it's not possible for him to come twice a week to the rehab.
okay, I see.
Yeah.
So you provide him with a home exercise and written exercise and review him on intervals. That would be it, right?
Yeah.
Okay.
Yeah.
Cool.
It's mainly the time constraint in short.
I see. Okay.
Yeah.
So posted the next question already.
How can his wife be a part of his rehab? First, ask her to check he is doing his exercises correctly. Ask her to report to the physio his progress regularly. She can encourage him to keep his rehab going. She can implement emergency treatment. Okay, great. Everybody says it's 3 because checking he's doing his exercise correctly. It's not like generally a PT, a assistant, like a physiotherapy assistant or physiotherapist can check out, and his wife cannot. She is not eligible for it. Even the progress, she is not eligible. The best answer, what I can think and what we can think is she can just encourage him to keep his rehab going. Yeah. And she can either implement the emergency treatment as she's not eligible to do that. So I feel third is the correct one. If anybody has why literally chose 3, you can say it.
Okay.
Guys, everybody agree?
Yep, I do.
Yeah, everyone agree. Okay, great. Mr. A now feels better. He is able to walk 500 meters and feels much less breathless on slope. He asks asks you if he can now he can play golf now, help more with the farm, and do some lifting. What is the most appropriate answer that you would give as his treating physio? Ask him to call his cardiologist and check with him. Tell him to go back to work and play golf and stop his rehab. Tell him that if he continues to improve at this rate, he'll be able to play golf in the near future. Tell him he won't be able to do such activities anymore. Okay guys, why I selected one is because actually concerning with his playing thing, I think we are not the person who will say that you can right now go and play golf. So I would go like it's better that he asks his cardiologist and check with him.
Right.
Yeah.
Yeah.
So somebody, I think I chose 3. I chose 3. Yeah, anybody who is Esther, you've chosen one. So what is the reason for you to choose one? The reason was because when I did the earlier discussions with the other guys, there was this lady that came to our group. Her name was Eva. She works in Melbourne, and she was saying with cardio problems, we have to always check with the doctor. You can't like tell him to. I mean, when it comes to cardio, you always have to go to the doctor. That's the explanation that she gave. And also looking at it, I think it would be the safest option. Though when I think of 3, because on the question paper that I had, the 3 was incomplete. They just said that you'll be able to go to play golf, but later they never said. Tell him if he continues to improve at this rate, he'll be able to play golf in the near future. Because of course, we need to remember that these are recalls, and people kind of remember differently, or in the exam it will be similar but not necessarily the same. So I don't know. I'm thinking of 1, though. Like also looking at 3 is not so bad. If he's continuing to improve, he might be able to, but I guess it's not for me to make that call. I would necessarily, most likely, the safest thing is to ask him to check with his cardio. Then, so I would still remain at 1. So my justification. Hello.
Hello.
Yeah. Yeah. Hi. My justification for answer 3 is the thing is he is still improving. So when he improved, when he improve in the near future, then we can send him to the cardiologist, and then he can do the test. So at the moment, the only thing we can tell him is that you can improve in the near future if you keep doing the exercise. Yes. Yeah, that's why I chose 3 as well. Yeah. Because they are given, the patient is improving, that is, so we can tell the 3. I'm also thinking about 3. And it says as is treating physio. So he's like already getting treated by us. If he's not improving, then we can send him to cardiologist. But he's improving. There is not there are no big problems with him. So we can go with. Guys, that's what India we do go with the doctors first because they take the final call. It's not like it's not like India or other countries. We do go with the doctor's call because they are the best person. Yes, as a rehab, yes, but then finally they give us a referral and we do the rehabilitation. So when we are making the patient again go back to the play, we need to ask their concern and then we can, because they have certain tests to do. So I feel yes. No problem. We'll just keep this question as a doubt for FB Facebook. Moderator Poonam or Tulsi, can you all please put this to Facebook and let's see what answers we get within a week.
I'll make a note.
Okay, thanks.
Yeah, sure.
Is that agreeable to everybody? Yeah. Yep. Yes. Just one question, guys. How long are the sessions? 3, 4 hours, 2 hours? Esther, depends actually. Last time we went very slow, but this time we are expected to go a little faster, so we complete at least this March and June paper, like March and September paper. So it should be around 2.5 hours actually, not more than that. All right, that's fine. Just curious. Thank you. Yeah. A 64-year-old female has had an abdominal surgery for removal of a pancreatic cyst. On observation, she is of thin build. She is complaining of shortness of breath at rest and is in considerable pain besides being on analgesics. Her chest X-ray has revealed minor bilateral infiltration. Her ABG findings are pH 7.48, PaCO2 28 mmHg, FCO3 26, PaO2 87 mmHg, oxygen saturation 90%. On her observation chart, her vital signs are recorded as follows: SpO2 96%, heart rate 110 beats per minute, respiratory rate 22, temperature 37 degrees Celsius, and BP 137 by 80. What do the ABG findings indicate? Compensated respiratory acidosis, uncompensated respiratory alkalosis, uncompensated metabolic alkalosis, and uncompensated respiratory acidosis. Everyone's agreed? Yeah. Yes. Yes. I'm still okay. I'm still here to put. I'm putting right now. Okay.
The next one is an interesting one. So anybody has any questions about this? Because ABG is a very interesting topic for a lot of people.
No, Poonam, it's I think since PaCO2 is decreased and since pH is even increased more than 7.45, so we go for uncompensated one because it's not getting compensated with HCO3 as well as the pH.
Right.
Yeah,
right.
Compensated is only. Yeah, correct. It has to, for compensated, the pH has to be between 7.35 to 7.45. Yeah, has to be that. What could be the cause of a tachycardia? Pain, hypertension, post-operative complications, anxiety. Okay, Parita is 4. Parita, can you explain why it was 4? Yeah, give me a second. I'm just trying to find the reference. Okay, sorry. Heli, why did you choose post-operative complications? Sorry. Yeah. It's maybe because of post-operative complication because of pain. She's not gonna have tachycardia. Like I don't know. Like I was not sure, so I just put 3 because I'm thinking that it may be because of post-operative complication. I don't have justification for it. I've chosen 3 as well. So when I was going through tachycardia as such, I tried to find out the causes of tachycardia, and mostly the main tachycardia cause is hypertension. But obviously we can't call her hypertensive because it's not bad, means her BP is okay. But other than that, it never said pain can cause tachycardia. I got a sentence from a prior that is, it is found with anxiety, exercise, fever, anemia, and hypoxia. And when on page number 11. Yeah, exactly my point. And if you check her BP is normal, so it cannot be hypertension. Post-operative complications not given anything as such except for her breathlessness. Guys, but that's what they have. She's in considerable. She is in too much of pain. That's what is given, and pain can be the reason of tachycardia. So I also visit one, but I got this sentence from the prior, so I told you. But is there any reference which says pain causes tachycardia? Yeah, because I'm not sure that if the pain causes tachycardia or not. Yeah, I don't think so. Yeah. Pain is not so severe that it can reflect on your heart rate. Reflect on your heart rate, yeah. It's no chance. Means because I checked like multiple places and nowhere it said, like it was always hypertension and means any other complication or whatever, but it was never pain. Pain.
Okay.
Alright, so maybe the answer could be anxiety. Yeah. Anxiety can be, but I'm thinking 3. Yeah, I'm more on 3 because post-operative complication. Actually, whenever we see the complications, it shows that post-operative complication can cause tachycardia. So I'm not sure what post-operative complications she has, but maybe. But I think it is not mentioned in the case anything about the complication. Yes, so we have to go with pain or anxiety. Anxiety. I think it looks anxiety to me. I don't know. And I read it somewhere, but I'm not able to find the. That is given on third edition prior. Page number 11. Yeah, but I think maybe we can just mark it as maybe let's okay as a doubt. Then we'll go back to it, just check extra. But since we are not 100% sure, I'm not sure about this. I thought because she's in considerable pain, that's why I picked it as tachycardia. But I know it's written in prior. I just need to check his board just to make sure. I don't about the pain. I'm not sure that part, but as in the causes of tachycardia are written in prior, so I just want to go back and read on it. But in terms of right now, okay, fine, I'm thinking maybe anxiety, since you guys are saying anxiety is written, but post-operative complications, I'm really quite doubtful because it's not mentioned that she could be having that, but I'm not sure. Yeah, I'm not too sure actually. I'm not like stuck with that post-operative complication. It can be anxiety.
Okay.
Let's just put it on paper.
Yeah, I've made a note about it. I'll put it.
Next question.
Yeah.
Her physio has taught her to do post-expiratory technique. What is the purpose of this technique? To correct breathing patterns, to improve lung volume, to clear secretions from the peripheral airway, to clear secretions from central airway. I think Parita's answer differs. Cough technique. Cough is for peripheral. Deep post-expiratory technique is for central airways. FET is for central. I thought it was peripheral to central and then it was peripheral. It is for sure it is peripheral. Peripheral to central, yeah, sure. Yeah. Because central is only coughing. Coughing, yeah. Coughing. Yeah. FET is for central, periphery to central. 3 is correct.
Sorry, but isn't FET, if it is part of the ACBT, the active cycle breathing technique, that it's then peripheral and central, but if it's only FET, then it's only really reaching the main airways? sense?
I don't know, but I think it is always. Guys, anybody has reference?
Yeah, I'm looking actually. I'm looking in Prime Prasad right now. Post expiratory. One 192.
Okay, now it's saying no, it looks as if it's a peripheral one. So the Huffing to low lung volumes removes the more peripherally situated secretions. And when secretions have reached the larger, more proximal upper airways, huff or cough from a high lung volume can be used to clear them, which is the FET, which is the
Okay,
expiration.
sorry, guys, same page FET. If you look the paragraph on FET,
Yeah.
okay, if you go through first, second, third, fourth paragraph, okay, ideally third or fourth paragraph, okay, they say a huff from mid lung volume is more efficient and probably more effective. To huff from mid lung volume, a medium sized breath should be taken in with the mouth and glottis open. The air is squeezed out using the chest wall and abdominal muscles. It should be long enough to loosen secretion from the more peripherally situated airways. Yeah. So yes, it is used for, and once it's in the central or low lung, high lung volume, cough or a huff can be used.
Okay. Yeah.
Okay, so it's peripheral.
Yeah, it's very important.
Okay.
And one about tachycardia, the problem I don't have the page because I have a picture. By the way, do we have a Facebook, a WhatsApp group?
No, we don't have a
no,
WhatsApp group. Yeah.
We don't have one.
Yeah.
Okay, I don't know. Okay, it's just a suggestion. Like, I think it could be helpful just maybe during the week, if we just have one, just in case, especially towards the exam, people tend to want to send lots of questions and opinions, and if you find something that we've been arguing or unsure about, you can always now post the answer to the group so that we don't have to wait for Saturday or for Sunday. That's just a suggestion. You can think about it. Then about this one, I have a picture. Okay, at the moment, I'll be able to send it if we make a WhatsApp group, or I'll try and send it on what do you
Skype.
call this?
Skype.
On Facebook.
Uh-huh.
It says, right, many different methods of pain relief directed to these different autonomical sites are available to patients. Several other factors may modify post-operative pain. These include the site duration of surgery and the extent of the incision and surgical trauma. However, physiological makeup of the patient and past pain experience can also be part. Post-operative pain is often accompanied by changes in the autonomic activity, which are sympathetically mediated and include hypertension, tachycardia, sweating, and decreased gut mobility. This is from the National Health and Medical Research Council, but it's from Prime Prasad.
Okay. No, because
Esther, which page? That's the problem. It's a picture. I don't have a page because my prior, I actually ordered it to come. I have the old one, Prior and Weber. I don't have Prime Prasad, but this one is from Prime Prasad. A friend we had a WhatsApp group, and they sent the picture there because we had a problem with this one as well. And the answer at the end was pain. Okay, Esther, can you just post it right? No, you cannot write.
on Skype, are you able
Okay,
to?
Esther, can you just? Esther, can you WhatsApp me? I'll just post it on this page. Can you WhatsApp me? Okay, right. Let me send it to you on WhatsApp, right? Yeah, I'll put it on the Skype group right now. So we're talking about the tachycardia question. Okay. Yeah, I want to go to the tachycardia question. Sorry. Okay. I sent the picture to you. Right. I mean, later on after the group, we can always make a group. Then we can be sending some of these pictures. Because I've got lots of pictures from some of the questions. Because I was in the September group. I was supposed to be writing in September, so I was preparing towards writing like 3 days or 2 days ago. But then I didn't get a visa to where I was supposed to write, and then I had to change to next year in March. So, but I still want to keep, studies that I won't forget some of the things. That's why I want to join groups, and yeah, because groups are quite helpful. They help to motivate you to study. So, yeah, yeah, but it's okay. I mean, I've made peace with it. I'm just moving forward. Yeah, but yes, it was really sad and painful, and I cried and everything. But now I'm okay. Right. So I've sent the picture to Komal, and she has the picture now.
Well, Esther, this is all part and parcel of life. Ups and
Yeah,
downs
that's true.
it keeps coming, and this is not the
That's
end
true.
of it. I mean, come on, it's all about picking yourself up and doing it again. Yeah.
That's true. That's true. Yeah. Yeah, and to take it positively, anyways, the September exam wasn't that great. So at least yes, yes. Yeah, people were telling me. And I think, one of the advice that I got from the friends who wrote in September, they were saying, I mean, if you were just reading the recalls only, you would probably find the exam quite difficult. It's good just to not just do the recalls, but also to read the topics like from the textbooks and just get the basic information, going back to the basics. And some topics, I guess, you just need to, if they talk about them in one of the recalls, it's just good to just research more on it and just to know something around the area. Of course, we can never really know everything that they're going to ask us, but I think if we call ourselves with not just recalls, but going to the textbooks as well, it will help when we come to the exam, we have like a broader knowledge, and even if the question comes different, you're still able to answer it even because you have a broader picture of the whole case. So, but not to worry. I think, the most important thing is just to try our best, really.
Yeah, that's true. That's true.
Should we go to the next question?
Yeah, I have
Yes, please.
moment. Okay, it's posted.
Yeah. What is the risk factor for post-op pulmonary complication in this patient's case? Age, COPD, metastasis, and opioid use.
I'm not sure.
Yeah, me too. Just a wild guess. But it's of pulmonary artery. Yeah. But do you guys remember we spoke about this last time, and we spoke about risk factors, and we said less than 65 years of age versus the low risk factor group. This might really contradict that thing what we spoke about. Yeah. Yeah, I think it's also in the IOPs as well. But over here, I'm not so sure if. Why are you going with opioid use? Isn't they said she's using analgesics? Is it the same as like opioids? Yes. Actually, yes, Esther, that's why I went with opioid use actually. So, because the metastasis cannot be possible because the pancreatic cyst is already removed. So, there are these chances. Age is above 65, I would consider that there is high risk. COPD as such not mentioned, and I wouldn't go for, it is a lower abdominal surgery actually. So there is no high risk of getting pulmonary complications. So and they said that she's on like severe dose of analgesics and the pain is not controllable. So I feel opioid use for me was the best.
Okay, Komal.
They have given she has revealed minor bilateral infiltrations.
Okay.
Uh-huh. So Yes,
point,
that's
you
what
are
I was.
missing the point. Yeah.
Okay. So with that one, I think I would even go to COPD.
Yeah, COPD could be
Because of that line. Because the thing is, I think because from the ILPs, the one I checked when I read this one, they were saying, but they gave lists of these drugs they were giving, like for example you have analgesics, right? Yes, they are painkillers, but they are weaker than opioids. Then we also have the opioids like the morphine and etc. Those are the ones that I would actually consider of opioid use. Maybe it's the way that I just consider it. I could be wrong, but I don't know if I would call analgesics opioids as well because they're kind of different. Or is it the same thing?
no, it's different. They use both the things, NSAIDs as well as the opioids. They both are different things.
Exactly. So I don't think if we could write opioid use because of that, but because we have bilateral infiltrations, then definitely I would put two.
Can anybody hear me?
Yeah.
Now
Yeah, you can. Sorry. The only thing that's baffling me is the fact that they've mentioned that she's very thin. And if you've got cancer and metastasis and so on, then you would, I guess, be very thin.
One of the reasons of bilateral infiltration may be the metastasis also. Maybe metastasis in the lungs can create that. So I'm confused with all these things. And the book which was given by the Komal, you gave the PDF, right? Cardiovascular therapy update.
Yeah.
Then in that patient-related risk factor, they given the age greater than or equal to 60 years, they are prone to develop the pulmonary complications, post-operative pulmonary complications. So I'm confused with everything.
Okay, nice, because all of them are the post-pulmonary complication, but we have to see in this case what can be.
So yes. So
Yes.
for this
Even if
case,
it's first
COPD or metastasis would be the answer. I don't know. I think.
Okay. Okay, I would disagree with metastasis because that information is not, of course, none of the information is really given. Fine, they say that she's thin, but being thin can be because of a reason of many things. I mean, people can lose weight if you have, maybe let's say you have problems with your thyroid gland, for example, you can lose lots of weight as well. I'm just saying, just giving an example, that being thin can be as a result of many different things. I don't think we can really say this person might have cancer because of that. So because of that, I wouldn't say 3. Then of age, like we say, it has to be 65 and above. Then the opioid use as well, I'm saying because of, but at the same time, I'm saying it's okay to think what we think, but let's just research more on it. But usually with these questions, they tend to give the information in the paragraph. That's why they even say, what is the risk factor for post-pulmonary complications in this patient's case? So in this case, looking at all the other factors, I would most likely put 2, but it's okay we can still add it to DAOs then to have, what other people think.
We will do one thing.
Mm-hmm.
We'll put this
Tell me.
question on FT and we'll let it get this out.
Yeah.
Okay.
Sure, I can do that.
All right.
Okay?
Okay. I'll make a
We are
note.
not deciding anything right now.
All right. Okay.
Case 3. Asthma scenario. Acute exacerbation controlled by medical line of management and referred to physio for further management. What would be your initial management? Allergy review, asthma action control, breathing control, postural drainage.
Yep.
When you talk about this, the reference which you have said is not opening, but I did look at this asthma action plan in Asthma Australia, and if you see, it's just a. Are you talking about the same that paperwork sort of thing that they give?
Guys, it is
Yes.
by, it can be given by doctor or nurse. It cannot be
Yeah.
given.
It's just a filling up thing. It's not really something that we are going to do because they're coming to us with that. It tells you, like, if there is any, are you having so and so breathlessness, are you having whatever, and then if there is an emergency, call 000. It's that's the action plan, no?
Yeah, they
Yeah.
also give directions on how to use the medication when you get an attack and stuff. So I think we have to explain them the use of spacer, and yes, it's a long plan actually. On
So I don't think we
how
can
to
consider
control.
that. That's why I took C as the answer. I did see the action plan and I was like, I don't think we are totally into that. Because
Right.
it considers like the emergency situation, it considers a lot of things in an action plan.
And it's
Guys,
what would be your initial management?
as a physio, right?
Yeah.
Should be 3, I don't know.
Yeah,
I
actually,
think it should be 3.
yeah, I think so. If you're talking correct, if just talking about the initial management, then it should be breathing control. Yeah. Sorry.
Yeah. Alright. What about the allergy review?
No,
That
no,
could
no,
come
sir.
later.
It must be done because it says that her asthma was controlled by medicinal line of management. That means the initial assessment of allergy review has been done by the doctors, I believe.
And we don't do allergy review at all.
Yeah.
So that's totally out of the question.
Alright. Okay. Thanks.
Thank you.
I think this question was put up on Facebook, and somebody said that it wouldn't be 1 at all. The problem was between 2 and 3, and yeah, as we're saying that asthma action plan is a very big process, which is not just done by a physio.
And it's not the initial management
Yeah.
plan by a therapist.
Patient uses MDI for salbutamol and also flixotide, propionate, that is fluticasone. He doesn't take fluticasone because he is unsure of what this drug does. He asks you what this drug does, and your response is, it is a steroid that reduces your airway sensitivity. It relaxes the smooth muscles of airway quickly. It will reduce the airway inflammation by relaxing airway muscles. It will make your sputum less thick and easy to expectorate. You might be the only one who has the wrong answer. See, the thing is that I did go through this thing, and when I went through the preventer, what is the definition of a preventer? See, this is what I got, and none of the definition actually coincides with those, so I was confused. So it says your preventer medicine reduces the redness and swelling in your airway and dries up the mucus. Preventers take time to work and need to be taken every day when you are well. And yeah, that's it. So it's mainly about redness and swelling and maybe inflammation. That's why I thought it would be 3.
But salbutamol is not a preventer. That's what they say. Patient MDI for salbutamol and also flixotide. He doesn't take fluticasone because he's unsure of what drug. Okay, sorry. Yes, here. Okay. Even I'm not sure, and even I need to think.
Because flicotide, propionate comes under combination. It doesn't come under preventer. But fluticasone is a preventer, and they're asking us what it is.
Yeah, but
we
I
have
think
to
if it's
talk
a
about
preventer, it's a preventer. Yeah, but from what you read, I will see that it reduces something. A preventer. You have to take it for a. Please read it again one last time.
Your preventer medicine reduces the redness and swelling in your airways and dries up the mucus.
Exact. Over here we have it reduces the airway inflammation by relaxing airway muscles. I don't know exactly how it does it, but over here we already have
it reduces the airway inflammation. That's why I would even go for 3.
Yeah, that's why I took 3 because I didn't think that. No doubt. I don't know how it is reducing the swelling and redness by the muscles. I don't know if the airway muscles are involved as such or what. But yeah, I thought that was the only thing which gave about inflammation. That's how I chose 3.
Yeah, that's why I would choose that one. Is just because of the definition that you gave. I'm thinking it's the closest to what we need.
I don't know. What do you guys think? That was the only confusion I had because yeah, 1 and 3 was what I had to choose from.
Mata, I read the same thing what you read, but I also read it will make airway less sensitive.
Less sensitive.
Okay. And it is not a combination. It is a pure corticosteroid drug. It is not a combination.
No. I'm talking about fluticasone is a preventer, but flucotide propionate is a combination.
No, but we are talking. No, it is. Both are the same. No. Yeah, you are right. It is flucotide. Yes. So
Yeah.
we have about the combination. And where are you guys reading for about the drugs? Where are you reading from?
I don't have prior reference, so I got this from another reference.
I read from the Asthma Australia. Okay.
Yeah, see, in fact, I have the preventer medications also, and fluticasone, fluticasone is a part of those medications as well. So, from where I got this reference.
Sorry, I did the asthma emergency management training in February, and I've got an asthma and COPD medication plan in front of me. And Fixatide is the corticosteroid preventer, but it's not a combination medication. So.
No, but anyways, the definition which I read was for a preventer only, not for combination.
Yeah, preventer. Yeah, it's only preventer, not the combination. Which would be 3 would be the combination because that's what the salbutamol does. It relaxes the airways.
My question to you all is, if it is allergic asthma, can any medicine reduce the sensitivity?
Yes. Yes.
Sensitivity,
Yes.
not.
Yes.
Oh,
Yes.
or maybe it can just bring it down by.
No, the prevention can reduce the sensitivity. If the pure prevention is given, it can reduce sensitivity.
I think I will go with Samatha 3 because even if you check online on various drug sites, it says it reduces inflammation and relaxes the muscles.
So you want me to check with Facebook?
Yeah.
Okay.
Yeah, I think so, because it's quite an important question.
Yeah, I think so. One second. This is okay. I'll put it there.
Next question.
Yeah, one moment. There it is.
How would you instruct the patient to use his spacer properly? Quick inhalation and 1 to 2 breath hold. Quick inhalation and 10 seconds breath hold. Deep and slow inhalation and 1 to 2 seconds breath hold. Deep and slow inhalation and 10 seconds breath hold. Everyone agrees?
Yes.
How can the patient monitor his asthma? Peak expiratory flow, peak inspiratory flow rate, spirometry, 24 hour sputum collection.
We don't have the question.
fast.
No, it's okay. It was fine, but I don't. I like to see. Then I'll be.
Okay, no, because I'm just in between, writing on my paper and also on what is that? And to make notes, what I have to put on Facebook. So
Okay, wait, I'll just put it over.
okay. Cool,
All right.
thanks.
Maybe what we can do, we can divide the task. Someone can be putting them over. Someone different will be making notes what goes to Facebook.
I
Because
put in
we are
this
quite
question
many
for
and
the
we can
time.
all divide. Sorry?
I put in the question for this one, which I just read.
Okay.
All right.
How can the patient monitor?
I can read, no problem. I can read for some more time. I'm all right till I leave.
Okay, Smarta, can you just put up the question? I can read. Okay, whatever. Heli, if you can put up the question, I can read. And Poonam, you just put it for the Facebook. I think so. That's better.
All right, sure, thanks.
Everyone goes with one?
Yeah.
Yes.
Yeah,
Should I read or is Komal reading? I can read for a while.
Who's putting up the questions?
I can put
I
it there.
think Katie.
I can put it there.
Okay. A 10-year-old child with cystic fibrosis. Her mother has been practicing head-down postural drainage twice a day. Why might the doctor not support gravity-assisted postural drainage as a form of treatment for this child? 1. Risk of gastroesophageal reflux. Children usually don't feel comfortable in head-down positions. Head-down position can increase intracranial pressure. Head-down position can cause cardiac congestion. Is that the next question already?
Yeah, put it.
The child's physiotherapist suggests using bubble pep to assist secretion clearance. How will this help her present situation? Make her independent in terms of her treatment? Effective secretion removal? Makes breathing easy? Improves her lung capacity?
Guys, sorry, I'm just sorry to interrupt, but this is what I got it from Australia, some website regarding fluticasone. So I would go with option 3. Okay, it has anti-inflammatory effects and relax bronchial smooth muscles. So I would really go for 3 as my answer for the fluticasone.
Okay.
Because everywhere they have mentioned the same thing.
So 3 it is?
I go for 3, yes.
Yeah, me too.
Esther, Jaspreet, everybody okay with that?
Yep.
Yes.
We're going with 3 instead of 2? This one makes breathing easy. Which one, Esther? Which one are we going with 3? You guys said Esther, the fluticasone, the asthma, the earlier case, question 2. Okay, all right, okay. And you said the answer is? I go for 3, yeah, because I have put a reference up. Can you see that? I'm looking for the reference. Okay, so much here on Facebook. Oh, you put already, or you copied. All right, that's great. Thanks. Mm-hmm. Thanks. Okay, so on. Thanks, 3. All right, guys, and it's from this journal. Okay, it's from this journal.
Okay.
All right. That's the latest one, so it's okay. Just safe.
Oh, not this one. Sorry.
Jaspreet, you go with one. Sorry, I think Jaspreet goes with one in this question.
Yeah, no, I go for second, not for the one.
Okay, sorry.
Yeah,
Okay.
yeah.
So everyone's with two, no?
Yes.
Yeah.
She is going to join a gym. What would you suggest her mother? Something appropriate to child's age and engaging her, aerobic exercises, perform secretion clearance techniques after the gym program, and all of the above.
She's only 10. Why does she want to join gym?
Oh, yes. I'm confused between 3 or 4. Like, can be, like, she has to do something appropriate to her child.
Exactly.
She can do aerobic exercise.
I think 4 is correct because you remember we had spoken about this, that in cystic fibrosis, because it's a long-term thing, you have to engage the child, and obviously we have to perform the clearance techniques. So
And
since both of them are,
for first option is like, she has to do something appropriate to her because she can't do everything in gym.
so I think it's 4.
Sorry, case 5, Smartha, can I read it?
Yeah, okay.
Case 5, cardiac prevention. A 50-year-old male has come for regular health assessment. All vitals look normal. According to the current evidence, how long the rehab program should run for achieving maximum benefits?
Not sure. I'm thinking maybe 4.
I think it should be 2.
But there's a site where we can check the answers. It's
Heart Foundation.
this is what? This is what? This is
Is it heartfoundation.org.au?
yeah,
Yeah,
maybe it's Heart Foundation. Yeah, cardiac rehab prevention.
Yeah. Esther, I'm on that, but it's difficult to find on that.
Yeah, I think maybe the thing is, with that one would need time to just go through it, because I know it's almost similar to the pulmonary rehab toolkit in terms of the duration. I think it's just a difference in 1 week or something, but I'm not so
Is
sure.
it 3 to 5 weeks? Why I remember it's 3 to 5 weeks.
No, definitely not 3 to 5 weeks. I think 3 to 5 weeks is too little.
I think it is about 4 to 6 weeks for sure.
Yeah, me too.
Yeah.
Yeah, 4 to 6.
But we don't have any reference for it though, and it's an important question.
Yeah.
Sorry.
Wait.
From which school do we have the cardiac rehab? Does anyone know?
What?
Cardiac rehab, from where do we study it?
Prior would be good. Yeah. Let me check the Heart Foundation website.
Yeah, that's the best one to find out because it's Australian standard.
Okay.
Is it heartfoundation.org.au?
Yeah.
I'm opening it. Yeah.
this part can't get rehabilitated in even us.
Yeah, I'm also there, but it doesn't show any timeline. It's not giving me. Yeah, it's not telling me.
Which part of the site are you on?
Huh?
Is it information for professionals?
Once, yeah, it is you and your heart. The first bit. Just put it. Then
That's
you
where
see
I am.
cardiac rehab. You know what we can do is that we can keep a lookout on this question. Everybody can keep a lookout rather than doing it now. But why I think that it's 4 to 6 weeks is because when I was working in Singapore, then we had kept our patients till 6 weeks for the rehab process. Yeah, so that I think is a norm.
Okay. A patient is asked not to work for more than 7 MET. What should he not do during this period? Walk at 8 kilometers per hour, climb up and down stairs, run on treadmill at 8 kilometers per hour, do weight training. Yeah.
I have a question, man. What is the difference between 1 and 3 if he's saying both of the speeds are 8 kilometers an hour? Whether he's running or walking, what difference would it make?
Right, I think this answer is in pulmonary toolkit.
Okay. Okay.
So we have given what the table which I was talking about.
Yep.
I think the answer is in that.
Okay. So,
Am I correct?
so what answer is it? Is it D, weight training?
I think it's run on a treadmill. I'm just looking at the scale and it's saying walking is 3, MET 3 or 3 MET, and jogging general is 7.
Okay.
And that's in Wikipedia. I just googled 7 MET.
I found one journal in which it gave you like a whole list of METs, in which staircase climbing and walking was within 7, but running on a treadmill and doing weight training, both of them were over 7. One was 12 and one was like 13 or something. So it has to be something either 3 or 4.
Okay.
But I don't know which one.
But okay, also going back to, I think it was
it's Samantha's question, which was saying, what's the difference between walk at 8 kilometers an hour and run at 8 kilometers an hour? Honestly, I think that's a really good question. What's the difference, really? Because the speed is the same, so the exertion will need to be the same.
No, when you run and walk,
Running exertion is more than
Then the walking.
But if we're going to say at 8 kilometers an hour, the issue.
You know what? It's
on a
very
treadmill.
it's very hard to walk 8 kilometers an hour on treadmill. You can only run 8 kilometers an hour. Like because I'm doing gym, so I can say that. I don't know what does it mean that walking 8 kilometers an hour.
And plus, when you're walking, they're saying on a treadmill. So the exertion on a treadmill has to be more because the patient can take halts when they're walking. On a treadmill, if it's at 8 kilometers per hour, it'll be continuous. So the exertion is like you're almost considering it as running and you're considering that as a walk.
Alright.
Okay. So I don't know if the answer is 3 or 4. It has to be one of the two. Esther, what have we put in the APTA group? The same question we were stuck at, remember?
Yeah, I think so. I just need to find them. Okay, let me just find my papers. 1 second. I have them somewhere. Right, I found something.
Sorry.
And I found something, but I'm not sure what it is. But it's saying that heavy lifting above 6 MET by running 6 miles per hour required 10 MET.
Can you speak a little bit louder? I cannot hear you. Sorry.
Oh, okay. I found the website. It's called Health Psychology homepage, and it's comparing weightlifting and running. And it's saying that heavy lifting involved 6 MET, while running was 10 MET.
But I have another reference which says weight training and running, both of them are way over 7 MET.
Oh, okay. I'm not sure how reliable it is.
It's like it gives you a whole list of means like all the possible activities and gives you the MET for that.
Where's that reference?
It's a journal. I can show you all the journal.
Oh, the journal. Oh, okay.
How about the second option? I'm not sure, but just asking
Just now only Samartha said that walking and climbing and doing stairs would be less than 7 MET, whereas running and weight training is way above 7 MET.
In ACSM guideline for exercise prescription, it's given that walking and climbing up and down is less than 7.
Yeah, that's what.
Yeah.
So like
even
we
in the
can do
ACSM.
less than
Climb up and come downstairs because you cannot walk at 8 kilometers. You need to run. So that is out of question. Even run on treadmill, that wouldn't go, and do weight training is also above 8.
Yeah. So because we have to stay below 7 MET. So if we are below it, that's fine. But if we are above it, then it's not possible.
Yeah. So what should he not do?
So run on the treadmill?
I would go with C actually, because in my opinion I think weight training you can still modify
the weight?
Yes,
Yeah.
you can modify the weights, resistance and stuff.
Right. So it could be run because once you're running, whether it's 8 or 4 kilometers an hour or 5 kilometers, you still increasing your heart rate at a much faster pace.
Yes.
So what do we do?
Do you want to put it up and we
Yeah.
can find out? Okay, I'll put it up. Okay.
The one on, going back, how long does it take for rehabilitation program to become effective? I found that the answer is 8 to 12 weeks because it's supposed to be greater than or equal to 6 weeks. So at least 6 weeks. So if we have 4 to 6, it's going to be a little bit less. But if we're going to have like greater than or equal to 6 weeks.
So can we go at 6 to 8 weeks?
Yeah, I think we can go to 6 to 8 weeks because it's supposed to be greater than or equal to 6 weeks. So over here we have 6 to 8 weeks. So at least that's what we agreed on the after group when we had the discussions. I'm looking for that one that of the METs. But I found that one first. I wanted to share.
Esther, which question was it?
It was case number 9 and question number 2. I mean on the after group. What
yeah.
On this one. You mean today? What number was it?
No, after group.
On the after group it was case number 9.
That is case number 9 is pulmonary rehab.
Yes.
So here we are talking about the cardiac rehab.
Over here we have. Sorry. I'm so sorry. Sorry. Sorry.
So we stick with 4 to 6 weeks.
Okay.
Yeah, but we'll still try to look up on this question because it's important.
Okay, yeah, I've made a note on it.
Yeah.
I made a note on it.
Okay.
Okay, I've posted the question.
Komal?
Okay, case number 6. It's on underwater seal drainage with suction on. If you have to mobilize the patient, what would you do? 1, 2, 3, 4. Is it clamp the suction drain near the chest and switch off the suction? Second, clamp the suction tubing and disconnect it from underwater seal drainage. Third is switch off the suction and connect the suction tubing to the vent and remove the suction from the wall and mobilize the patient.
I don't know the answer for this.
Yeah, because you know what, when over here the highlighted one is actually B, and clamp, Komal, last time we were discussing that you said that clamp, we don't do clamping.
Yeah.
So
I was thinking 4.
even I was thinking 4 in that case.
Yeah, 4 is a better answer actually.
This question is repeated so many times
Yeah.
in the same record.
Yes, Esther, do you want to say anything?
No. I was just going to say I think 4 too. I mean, with all the options that we have, I think 4 is the best.
Yeah, even I think 4 is the best. Lady with pulmonary fibrosis with description of vital signs. What can you hear on auscultation? Is it fine crackles, absence of sound, or bronchial sounds?
Not sure.
It's 100%. 100%.
Yeah, inspiratory crackles.
Yeah,
Fine
one.
crackles, yeah.
One.
Yeah.
Yeah.
Fine.
Saliva.
Okay.
How can 6-minute walk test be used to prescribe the intensity of exercise of a patient for rehab? One is using the number of meters that patient has done in the test, level of dyspnea during the test. This is also the repeated one.
Yeah, I think we have discussed this in last session.
Yeah.
Samartha, it's not level of dyspnea, remember?
It's one? No, I was confused. I thought, yeah, okay.
No worries. Heli, anybody who doesn't go with one as their answer?
No, it's one. Yeah, it's one.
Esther?
Yeah, I'm also okay. I didn't answer, but it's okay. One is fine.
Perfect. The patient gets breathless when combing her hair. Which type of exercise will help her? Oh God, this is again a problem.
I know.
Yeah, and
We were doubtful.
all the questions are repeated.
Yeah, a lot of questions are repeated.
And they're all irritating questions, yeah, which has no answers.
I think the patient, whoever made this recall, did not know how to use Word. Just repeated the same questions again. Did we end up with an answer for this one, but
Yeah.
Strengthening.
Yeah, people are saying whether it was a unilateral arm exercise or it was upper limb strengthening. And there was a debate going on Facebook on that, and people, as usual, were fighting about their answers, right? But
but what's the answer?
but somebody, I posted my this thing, no?
The feedback.
Yeah, the feedback. In that, there was an answer. There was a good explanation given that it should be a unilateral exercise because the patient is frail and elderly and weak. So we won't be doing strengthening for her just yet. So we start, and she's not even able to do any aerials. So we start her off with unilateral arm elevation exercises.
Is that the answer?
Yeah, that's what people have said on Facebook.
Oh, I was thinking of one.
Yeah, that was what we had come to a conclusion.
Okay,
when
and
we discussed.
the other options of this question are relaxation exercises, that's the third option, and fourth is upper limb strengthening exercises.
Yeah.
So this four are repeated in multiple papers, but there's no, I don't know, everybody says the different answers. Esther, what did our moderator say? Do you remember?
About this, well, what I remember was it depends on what you call this, what the question actually says. If it is, okay, was with one that we had, I think it had more answers. It didn't just have these two. Over here we only have
Yeah, that's what
Let me
it
just-
has relaxation exercise, and the fourth one is
Upper limb strengthening.
Upper limb
for
strengthening.
first sleep or something. But let me just open. I think I have it over here. I'll just send it over, and then you guys can because somebody was writing the explanations on the doubt questions. So I'll just post it over here on our Skype. Then you guys can also have a copy of it. Let me see if I can just find it. 1 second. Then I can open Skype sessions.
Yeah, so we couldn't find it because we were not convinced with I think the answer or something like that.
Oh really?
Yeah.
All right. Let me just check because what happened was after we finished, right? Carrie was writing down some of the things that the moderator was saying because I had to leave in the middle of the session. So she sent me a copy. So let me just open it. Then let me just make sure. All right. Okay. So you guys, Do you mind if I put it over here? Then you guys will have the question paper too with the answers.
Yep, that would be great.
All right, let me just save it. Sending. I've sent the paper.
Okay, thank you.
Now I need to open and find the question.
Oh, okay. I just let you know which is the question. I just in ASTA it is question number. Is same.
थोड़ी देर
47.
47. All right.
47 question 4.
Okay.
So the paper which she has sent, is it in that comma?
Yeah.
Okay, case 47. Case 47.
Yeah, case 47 number 4.
Okay.
I'm not able to open this file.
It is being opened.
I have to add if first, then I can get this file.
All right. You can add me.
Yeah, so it's upper limb strengthening. That's what I see over here. Your answer. Is it?
Okay, guys. Even the cardiac one, the cardiac questions, even the answers are there. Case 64.
Mm-hmm.
It's run on treadmill at 8 km/h.
Okay.
It's more than 7 minutes. Yeah.
So that's the one, right? The running one. Okay.
Yeah.
Yeah, you see over here, so the answer is unilateral arm elevation exercises. It's not strengthening.
Yeah, according to what we did.
Yeah.
Yeah, but I mean, in all these things, I think 90% of the maybe answers would be perfect, to be correct. But it's always good just to have your own reference. I mean, if we are not sure of something, at times if your gut is telling you something different, just good to just go back to your book and check. Because I mean, in as much as she even wrote that she wrote as much as she could. So at times, she could have made a mistake or misunderstood something. So it's just to listen to what has been said, but also always have an open mind that this also is a human being who could make a mistake.
Guys, like even the Flixotide, the drug one, they still go with it reduces the sensitivity of airways. The answer in the file which Esther sent, like the APTA session, they go with it reduces the sensitivity of airways, but I would go with the inflammatory one. So it can be like, it's not that it's 100% right, it can be wrong.
So it's good to help us, but when we're not sure, we just continue to check for our own answers. I think we still have a little bit of some time, but yeah.
Yep.
But with that question, with fluoxetide, you had it was first. What was okay? For what I would do is, I think it was there in the 2005 paper. Right? I'm
Okay,
not
was
sure.
it there?
I think so. I'm not sure. I'll have to check, but it looks quite familiar though. But I'm not sure. Everything is now all mixed up in my mind. Yeah, but anyway.
Oh yes, guys, the 2005 paper, they have given the answers also. So we can add that, like we can read that. Because they have given answers with the justification why. So many of the answers are there in 2005 paper. Guys, can we go to the next question? Nasty question.
Okay, I posted it there.
Sorry, which question is this?
This is good question, because I think it's case number 8 or 9.
It's 8.
8. Okay.
8.
All right. Komal?
Can we go ahead?
Yeah, the question is already there.
Okay. So the last question we go right now with unilateral arm exercise.
Yep.
Okay, great. Male 40-year-old asthma patient. He wants to know what is the function of Flixotide. So it helps to reduce the sensitivity of airway, helps Putin. So I would go with A.
Seems like it's A.
Yeah, me too.
Yeah, seems like it's A. Esther, Jaspreet, Parita, Tulsi, Martha. Yes.
A.
Okay, guys, he is now stable and the doctor refers to physio for breathing control, allergy review, asthma action plan, and there was one more. It is the repeated one. So what ACTA group has suggested the answer as allergy review.
Okay.
Yes. So if anybody gets allergy review with as an answer, just let us know. But right now, I would go for breathing control.
Yeah, I do for breathing control.
We have marked as the allergy review.
Okay.
But that's not our concern, yeah? Allergy review.
Yeah, but I think that's what the people that came to APTA agreed on. But the thing is, you know what happens with the APTA groups is, first of all, we have a meeting as just the students or the candidates. Then we pick a few questions that we'll give to the moderator. So not everything is discussed by the moderator. So that's why we're saying let's just keep an open mind. So now I guess, yeah, I think I would go with what you guys said, breathing control as well.
A, yeah. A is the best answer.
How to monitor his asthma, spirometry, PEF or FEF?
They have not given who is monitoring it, like therapist or the patient.
But still, if you go with Australia standards, they recommend PEF. So we always go with PEF.
Okay.
How to use the spacer, which is again a repeated question. So it's it's deep breath with 5 to 10 seconds hold. It's generally if it's 5 to 10 seconds hold. Yeah.
You guys, okay. PEF, what does it stand for? Once again.
Peak expiratory flow.
Okay. Thank you. Thanks.
Is that a next question? Yes.
Yep, that's the next question.
Yep.
Old patient with fracture in ribs. Physio treatment is ACBT, support, cuff with pillow and pep.
This is a battery call.
Call. You cannot give pep. I think so. Guys, it's a bad recall. There's nothing.
Yeah, it's a bad recall.
Please send enough information.
Yeah.
Next one.
Post-operative patient after hemicolectomy and X-ray shows bipassal opacity. Exercise for this patient: incentive spirometry, PEP.
I think it's a bad recall.
It's a bad
Guys,
recall.
it's for 55-year lady. Post-operative hemicolectomy for tumor, drowsiness due to opioids, risk of post-operative pulmonary complication. It's COPD, opioid use, age or cancer.
Now, if they have mentioned opioids, then it should be opioids.
Can you post the next question?
Yep.
She has a drop in SpO2 of 88%. What should you do? Tell the nursing staff, delay the treatment for other day, apply O2. Guys, I'm not sure because that's what our moderator said that in Australia, the SpO2, even the physios are allowed to give O2 to the patient. So they have full training of how to apply an oxygen mask and what percentage the oxygen has to be delivered. So it can be applied. No, cannot be.
Tulsi, we read somewhere, you remember that whatever happens in ICU, the first thing to do is to contact medical officer or the nursing staff.
I read somewhere, but I can't get it.
Even I'm not sure where did we read it, but
We can go with Esther. Any idea what?
Okay, but I was going to think that, like I think we had a similar discussion, but the problem was, I mean, in the room where you have the patient, you have this, I don't know, is it a button that you can press, and the medical staff will be there within 30 seconds because they won't pass there.
yes.
So if you press it, then they will definitely come in and But I think you could also add the oxygen because, I mean, if somebody, in this case, 88% is not so bad. I think in the question that we had about 50%. The question that we had during the after session was if you find a patient is at 50%, what would you do? Then I think the physio had gone to do her morning rounds, and then she found that the patient is at 50%. But I think they were able to communicate. They were talking, everything. She was conscious. So they were saying, I think Lavanya said what she would do is to check if it's correct, because it could be a wrong reading since the patient is drowsy, things like that. So I'm still a little confused over here. I think telling the nursing staff would be good, but if it's 88%, I mean, I think definitely on the exam would have more answers. But over here, I'm not sure of the options that are given, if they are all accurate. I mean, if they are complete. So if I have to choose over here, definitely delay treatment, definitely apply oxygen, maybe telling the nursing staff. That's what I would do. In this case, with these three options that I have, I would go with telling the nursing staff. Because 88%, as long as she is conscious, I would just mention it that this patient is still at 88%. Maybe we need to test and check if everything is okay. But apply oxygen, maybe not immediately because 88%. But I'm not sure.
Yeah, but practically, you're right, because it's 88%, so it's not that down. So better we inform the nursing staff and they can take over it.
Yeah, so I think the best answer which we go would be one, inform the nursing staff in this.
In this case, yeah.
Yeah. Okay, what can influence in SpO2 accuracy reading? Is it shivering of patient, vasodilation, low light in room, or everybody goes with A? Heli, Esther, Redka.
Sure.
Yeah, I'm sure it's A. It's one.
Yeah, me too.
Positive.
Me too.
Okay.
Because in terms of the answers that are given, if you look at low light doesn't really affect, but what affects is bright light, ambient light. That's what affects the reading. It can be incorrect if you have bright ambient light. Then vasodilation, I don't think so. I'm not. I'm sure it's
Vasoconstriction. This vasoconstriction affects the reading. Vasodilatation will not affect the reading, but vasoconstriction will affect the reading.
Okay.
Yeah, so in cold, if the patient is feeling cold towards the periphery, he will have vasoconstriction, and there will be also coldness in his fingers at the periphery. So that would affect his warmth, and that would affect his gauge of his SpO2.
Yes. Okay. The booklet which was given by Komal, everybody check the page number 48. It's given detail. Everything is given in there.
What is that?
That is Koval physio qualified physiotherapist, cardiorespiratory physiotherapy update.
That's crop file, Lester.
Yes.
all right. Okay.
Crop file page 48, is it?
Yes.
Okay, cool.
Right, everybody has that?
Yeah.
Source of error with pulse oximetry.
Shivering or tremor.
And they explain that
bright light. Okay. Can we move on to the next question?
Yeah, it's already
Reason,
posted.
kid with cystic fibrosis. Reason why gravity-assisted postural drainage is not appropriate. Again, it's the same question. Risk of gastroesophageal reflux. That's A. Next, use it 30 minutes a day. Use it till secretions come up and do a half. Use it when you need it. Yeah, I think I'll go with A. But let's bear in mind, I think this one, is it the one that you do in cycles, right? The PEP? Yes. It's the same. It's the cycles one. Cycles one. So there will be a different question with more options, and we have to go with the cycles one. It takes 30 minutes, but you have to have cycles. But I mean, with the options given, I guess the first one will be the best one. Best option. Yes, if you read Alexandra Half, page 221, it's like the best answer is use it in cycles with half or cough to clear secretion till none are left in lungs. Yeah.
So
guys, everybody who's answering 13 minutes, where is the reference? Like which reference? No,
I would say B, because use until the secretions come up and do a half.
Yeah.
I don't have reference for it, but that's just my practice phase.
So what are you saying, Komal? What is the answer?
The answer is best. You need it to use it in cycles with half or cough to clear the secretions until none are left. Remember last time we discussed, it's there in Alexandra Half, page number 211.
Okay.
I think it's also there in the crop file as well.
Yeah. So which option is it? A, B, or C?
Over here, I don't think we have a good answer, but maybe B would be better. But the best one would be to do it in cycles and to remove the secretions. But there is a question with Enrico with all the good options of cycles, etc. But I just don't know where it is at the moment. But I think in this file that I sent you on Skype, if you go through it, you'll find that same question. But it will have more options.
Okay.
That question is back again.
Yeah, that question is back again. Even the second part,
Okay, asthma scenario, acute exacerbation controlled by medical line of management and report to physio for further management. What will be your initial management? This was a FB question.
Yep.
Repeated question. Don't we go with breath control? We are not sure about allergy review.
Yeah, we're going with so far we've discussed we go with the breath control, breathing control.
Yeah. But if possible, you can just put it on FB.
Can, no problem.
If you guys not
Thinking about B option at all?
No. I'm sure about it because it's clearly written on asthma.org.au that it's by nurse or a doctor.
you on which I had sent you before on this Skype.
Yeah.
I'm sure about that. It's not asthma action plan. Can't be by us. Because they have said clearly that it's reported to physio for further management, and what would be your initial management? So I would definitely not go with that.
Actually, it has to be prepared with a doctor.
Yeah. Okay. Question 2. Patient uses NDI for salbutamol and also Flixotide. He doesn't take fluticasone because he's unsure of what does this drug does. He asked what this drug does, and your response is, I can go with 3, not 1. But Esther, in an APTA group, they have mentioned 1 as the answer.
Yeah, I think that's what they did. But I mean, like we said, they're also humans.
Yeah.
So I'm thinking, I think 3 is better.
Okay.
Yeah, but I mean, we can always just research more and see if it really does relax the airway muscle. Because like I said, I think this question is in the 2005, and I think they picked 1 because that's what the official answers were saying. But I'm not sure. I just have to go back and look for it. I'll look for it, I mean, later today.
Exercise is a preventer, right?
Yes.
Yeah, it's a preventer.
Reduce actually the sensitivity.
But it is a combination. Exercise proprionate.
Guys, next, how would you instruct the patient to use this spacer? Again, it's a repeated one, and the answer is 4. Deep and slow inhalation and 10 seconds breath hold. Everybody agrees?
Yes.
It is generally 5 to 10 seconds. So, in case if the question is twisted. How can the patient monitor his asthma? It's again the same question as expiratory flow. PEF, peak expiratory flow.
So can I just go back to question 3?
Yes.
The advantage with a spacer is that you basically do normal tidal breathing with it. So you do not quick breath, you do deep. But why do you think it's a 10-second hold?
It is given in prior.
It should be more than 5 seconds. So when you the breath hold should be more than 5 seconds. So if you check the options, that's the best option available.
If you Asthma Australia, it has a video which says 10 seconds.
Oh, great.
It shows you how to use it and it tells you to put it for 10 seconds. Okay, a 60-year-old female has an abdominal surgery for removal of pancreatic cyst. On observation, she is a guys the same question.
Yeah, it's repeated the entire
Okay, so let's do one thing. The answer for this was uncompensated respiratory alkalosis. Everyone agrees?
Yes.
Okay. The second question, what could be the cause of tachycardia? Here we were confused between pain and anxiety. So since it has been given that she was on pain, and even if she was on analgesic, she had considerable pain. So I would go for pain, but many of them do say anxiety also. So it's I think we can put this to FP, but I think Esther cleared out saying that it can be the reason for tachycardia.
Which one? Anxiety?
But over here we don't know that. Okay, fine. I mean, we've not also been told that she's anxious. So why would we pick? I mean, yes, anxiety is a cause of tachycardia, but they've not said that this particular patient, is anxious about anything. So, and plus that picture that I sent to Komal, I don't know. I'm with pain, but I mean, we can still post it to FB to find what everybody else thinks.
Okay. Her physio has taught her to do post-expiratory technique. What is the purpose of this technique? We all went to 3 to clear secretions from peripheral airways.
Yeah.
Yes. Everybody agrees? Okay, great. What is the risk factor of post-pulmonary complication in this patient's case? This is a moderator, like this is a doubt question where we go for either COPD because they said that her BP minor bilateral infiltration. So we were confused between COPD and opioid use.
Right.
Okay. So Poonam, just make a note on this.
Yep. I'm making.
Okay. Case 90, which is again a repeated question, I just go through quickly, is on cystic fibrosis. First question, why might the doctor not support gravity-assisted postural drainage as a form of treatment for this child? It is because of risk of gastroesophageal reflex. Everybody agrees? Okay.
Yes.
Question 2, the child's physiotherapist suggests using bubble pep to assess secretion clearance. How will this help her present situation? Okay, guys, bubble pep, generally it's under supervision, so it cannot make her independent in terms of her treatment. So the best answer was effective secretion removal, as it's a airway clearance technique. It's actually the PEP is best given in the crop file. So the contraindications are also very well given in that. So guys, have a read on that. Okay, she is going to join a gym. What would you suggest her mother? Something appropriate to child's age and engaging her. Aerobic exercises. Perform secretion clearance technique after gym program and should be with her all the time. So what do you think here now? This is it's the same question with different options. There is no all of the above in this. Yeah, but I think maybe, I don't know, but I'm thinking, with these questions, they come in like we have 5 options, and if we have 4 options, which the 5th one is missing, and it's a recall, so maybe, I don't know.
Yeah, could be a bad
recall, maybe there is all of the above, but it's just not written. I don't know. Just take it that way. Okay. Case 6, 50 years old female was admitted. Can somebody post it, please?
Yep.
Okay. Case 6, 50 years old female was admitted with asthma, has allergy to dust mites, pollen, and symptoms increased from 3 days, admitted to the hospital. Salbutamol and flixotide was given, and an asthma is being controlled. What does the doctor tell physio to do sputum clearance direct control? What does the doctor tell to do sputum clearance direct control?
Maybe the person who has recalled it just remembers the question and doesn't remember the options given,
Okay, fluxotide was given. What is it? It's a preventer. Again repeated.
Preventer.
Yes. Okay. What's the rationale of the spacer? Even spread of drug in airways because it's cheap and increases compliance. It decreases candidiasis infection, easy to use and takes less time.
Okay.
How will you measure her respiratory function? Again, it's the same thing. It's PEF.
Yeah.
Okay. Hemicolectomy. What would be the most likely complication after surgery? Case 7, hemicolectomy. What would be the most likely complication after surgery? Now, all the answers are pretty much.
Yeah, I think even I'm gonna leave now. Sorry, guys. Carry on.
And maybe I'll just ask somebody if next one is to make. Okay.
Bye. Bye all.
Sure.
Bye-bye.
Bye bye. Enjoy yourself. Take care. Bye.
Bye. You check the pulse oximetry before mobilizing your patient. The reading is 49%. What do you do? A, B, C, D. Esther, this was the question, right?
This was the one exactly that we had last time, yeah.
Okay.
Yeah.
So
So
what
you
did we select as our answer?
49%. I think since it's 49%, I would go with give oxygen, honestly.
Yeah. I would have done the
Can't give
same.
oxygen and it's way below 50. I mean, it's like it's not even, it's even below 50%. So I'm thinking I would go with 3. But I think the moderator said that she would check if it's correct. But that answer is not even given over here. But if the patient is conscious, then definitely I would check if everything is okay. I mean, if maybe because the oximetry reading could be wrong, inaccurate, so you could just check to make sure if everything is okay. But in this case, I would definitely go with 3.
Yeah, because in this in Australia, I went to the one of the hospital because I know about it. So in ICU, they usually have the red button. So so you just need to do when if it's 49%. So you just need to press the button and then you can continue with the oxygen. So I'm not sure about the answer, but yeah, I can go with that answer. Like you can go with oxygen, supply of oxygen. So are we allowed to do that in the ICU?
It's just again, it's saying that give the patient some oxygen. That some oxygen is somehow bordering. Like some means what?
Yeah, I agree.
Like some means they should, like if we are held responsible for, say, we can give oxygen, say we go with that, where you all guys are saying I have no idea, like pressing that red button, but there should be some like indications, like what some means it can drop down, so we have no clue like what does some oxygen means.
So guys, I think we should
Still thinking
again ask.
is it safe? Yes, sir.
I was just wondering, if you would have a reading of 49%, how would the patient actually be? I mean, to me, it's a real emergency situation. So I would tell the nursing staff and then give the oxygen.
Yeah, so it's better to, on our safe side, because here in Australia, if you see practically, if you do anything and if something happens to patient, they're just gonna kill you.
Yeah, well, I work in the UK, so I'm not sure how different that is, but I mean, if the
Guys,
patient
again,
has
we
got...
can put this on Facebook and we can really get with answers like and select what we want.
Okay. I'll put it there.
It's too subjective actually.
Okay.
Which of the following can change the pulse oximetry reading? It's again repeated, so the answer is 1.
1 year.
Sorry guys, what's wrong? Okay, which of the following can change? Okay, case A, surgery, thoracoscopy for wedge resection of right upper lobe. What is a normal underwater procedure bleed for normalized air leak? Esther, just please read that.
I'm still reading. I'm still.
Sorry, Esther.
It's okay. I'm just thinking, why not? One sec. I'm confused between this. bubbling in the suction chamber is quite normal. So why not C and why A everybody is marking?
There is no bubbling in suction chamber, I think.
They usually say that like if the underwater seal is there, there should be some bubbling observed in suction chamber, but there should be no bubbling in the suction seal drainage, water seal drainage. So why the intermittent?
If you just see the crop file no, for this as an answer.
Okay. But then bubbling in the suction chamber is normal, right?
No, but you also
But they
don't.
haven't mentioned intermittent or continuous, so I wouldn't go for that.
Yeah, that's what I
When
was
I
saying.
asked normalized air leak, does that mean that basically the air leak is about to close or is closing? That's how I understood that. And that's why I thought it's intermittent. Does that make sense?
Guys, the answer for this is given in Pryor and Prasad also underwater seal drainage.
I think we've also discussed this in the last round also.
Yeah, but then,
Yes.
so Prasad is that there should be no bubbling in the seal chamber. The seal chamber should be bubbling in the suction chamber. So that's what confused me. And Prasad gives that there should not be bubbling in the water seal drainage, in the water seal drainage tank.
Guys, can you all see the crop file? Which page?
Yeah, I think I'll just check that, and maybe if I'm still confused, I'll come back to you guys.
Yeah, I think we can check, and then anything then we discuss again.
Okay. Yeah.
So just read all of y'all. Do you all agree with A?
Okay.
Yeah. When mobilizing the patient, how would you manage the brain? It's 1, 2, 3, 4.
To the frame.
Okay, guys, they generally fix it to the frame. Yeah, that's a normal standard. Yeah. One was answered 4. They have asked how would you manage the drain. They have not asked anything about the suction and all. Hello?
Hello? Yeah?
Say again? Yes.
Sorry, what's your question?
Do you agree with 3 or you still go with 4?
For the previous question, right? We agree with 3. That's fix it to the frame, right? Yeah.
Yeah. And you touch it to the frame. You have to have it quite a bit lower. So when you're mobilizing the patient for the first time, I would actually have it on the floor initially and then put on the frame. But maybe I'm not understanding the question right.
Generally, you put you attach it to a frame and then you mobilize it.
Yeah. That would be the one. Attach it to the
Does
frame.
anybody agree to it?
But you have to take the section up or not first.
After mobilizing him, what would you do to manage the, after mobilizing him, what would you do? Make him sit on the chair and say, the nurse will take you to the bed. Ask him to stay in the chair and after resting for a few minutes, practice breathing exercises. Ask to half strongly with pillow support and put him back in the bed.
Everybody has a different answer.
So everybody gets to find their answer.
People who say C, Y, C, and people who say 2, Y, 2.
Three, that's some of the feeling. Okay, you have to go. Alright, the first one is one. Nobody chose that one. I'll go with mine. Mine was 2. I said, ask him to stay in the chair and after resting for a few minutes, practice breathing exercising. I think, yeah, it's good for him to rest a little bit. And after exercising, also after walking, the secretions, they are a little bit stimulated, or it's easier for you to remove them. So that's why I'm saying with breathing exercises, for me, I don't know, when I think of breathing exercises, I'm thinking of breathing also with fasting as well.
Okay.
So it's just breathing only without fasting. But I thought maybe I would go with it because that's what I thought.
Guys, the answer for this is ask him to hug strongly with pillow support actually. The answer is in Prior and Prasad, new edition to page 154. Guys, in Prior and Prasad, new edition, can you all check?
Page 164, you say?
154.
Did anybody get it? Sorry. Because I thought it just say tapping on it on. Not sure if, literally you have to take it down. I thought, okay, never mind, yeah, bad idea. It's still a test. So that is what we discussed with Akia group. Page 164? Yeah, guys. I don't remember this one, but it's okay. All right, let me just find it. That is chapter with mobilization and positioning. Okay. Everybody agrees to that?
C, right?
I'm agreed to that.
Ask half
One
and
thing, who already said three, who already said three as the answer, like ask to hug strongly with pillow support. Do you all have any reference? No. Thinking that it has to be mentioned that he has got any any signs of his chest being bad. He will be in pain because of the drain. There has been some of his lungs, but I think it's more important for him to know how to cough if he needs to cough. So that we're having more
Sorry, to say again.
There is no direct reference, but where a person is huffing with a human.
I'm here. Hi.
Komal, are you there?
Yeah.
Okay.
Right, can anybody read out? I can read. All right. Case number 9. Had we finished with the other question?
Yeah, that was C. That was C.
We will try to find the reference.
All right.
And if anybody gets the reference, we will discuss in the next session, right?
Yeah.
All right.
Everybody try to find out the reference.
That's fine. All right. Case number 9. COPD and asthma of a 60-year-old woman. Permanently on oxygen, gets breathless on simple activity. Initially used to have 1 liter of oxygen, now increased to 2 liters. She can only walk from her room to the bathroom and living room. The BMI is 14. What does this mean? One.
1A.
Yeah.
Then someone
Next
have the range, like they say less than 20 is underweight, 20 to 25 is normal, it is normal, 25, 30 is overweight,
And greater than
and above 30 is obese. Am I right?
Yeah, that's right.
Yes, you're right.
Yep.
I can next question. All right. What can we do to improve her breathlessness? We have 1, relaxation, give her gentle strengthening exercises of upper limb. Then we have breathing exercises to give her more oxygen. I think we agree that the answer is 2, right?
no, it's different. It's something different.
It's a little bit different. It's a different one.
Yes, it's different.
Possibility of oxygen.
I think
What do we think?
I think I'd go with I don't know why I go with C.
I also go with C.
What about you, Komal? Ah, okay.
So for 1 or 3.
Okay.
Yeah, one is like relaxation of what? I like relaxation, just rest in the bed, or relaxation exercises.
I think relaxation techniques.
Okay. Don't know. You have to get massage.
We have the same question in ACTA group. Can somebody check the answer for that? Sorry, I don't have. The same question in the ACTA group.
Yeah, we have something similar. My problem here is we have to improve the breathing control, etc. But breathing exercises. But I'm thinking, what if maybe for a long term, then later on she won't be breathless. But over here is just going to help her at this time. But what if we give her gentle synthetic exercises of upper limbs, then she won't. Anyway, I don't know. I'm confused. I'm trying to think.
Yeah, because if you look at the question, it's saying what will you do to improve her breathlessness. So if right now she's breathless, then we'll actually give her either breathing control or we give her some oxygen. But I think more than the oxygen, it would be more like better to have a breathing control exercise for
Yes,
her.
already she is on 2-liter oxygen.
Yeah. Okay.
All
I
right.
mean, would you say that her lip breathing is a breathing exercise?
It will,
Yes, it is.
yeah, it will
So
fall
I
in
think
that. It will fall in that.
that's what I would teach her,
Yeah.
so that she can use the oxygen for longer than she's already getting.
Yeah.
So that's what I would say.
So we go with C, everybody.
Yeah.
Yeah.
So we go with C.
Yeah.
Okay.
Next question I posted.
Next question. What X-ray show? Okay, what will X-ray show? We have claustrophrenic angle decrease, diminished shadow, which is right heart border, and claustrophrenic angle. Then we also have diminished shadow of left heart border and full elevation of the diaphragm.
Is that a bad recall?
Yeah, because I was also thinking the same thing that it will help to show your elevation of diaphragm. Yes, it will also help to show costophrenic angle and diminished shadows. So I was between B and D.
Do you understand that as a generic question? What does an X-ray show, or what does the X-ray show in this patient?
No, I would think
I think
it's
in this patient. In this patient.
Guys, so what's the answer for this?
Not sure.
what do you guys think? I'm stuck between B and D.
I'm not sure.
I think we
I'm not sure.
I think we all are getting a little tired now.
Yes. Esther, was this question in our actor group? No, right?
I'm not sure anymore. I'm not sure. Maybe it was there, but I'm not. We just have to go back and check. We have the question. Yeah. Are we also meeting tomorrow?
Yeah.
What time? At what time are we meeting tomorrow?
8:30.
8:30 morning.
No, night PM. 8:30 PM.
All right. All right.
Guys, have they mentioned what lobe is affected in this? Nothing, right?
No.
Not affected. Sorry, can I have the question again? Sorry. I would go for B actually.
Uh-huh.
To be very, if it's
Right, right.
Because the same recall is there in some different paper, and they have written that the patient is admitted with right middle lobe pneumonia with a background of history of COPD and bronchitis.
Okay, okay. I
So
see.
there's the same recall, same option.
Uh-huh.
So
Okay.
I'm just wondering COPD and asthma, but they haven't given. Because in asthma you don't see phosphogenic angles decrease, you always see increase. Am I right? I'm not sure about this.
Because he will have more like he'll have a flail chest in asthma, right? Yeah. Yeah. I'm not sure actually. I'm not sure exactly.
Okay. So let's keep this as doubt question. You can post it on Facebook.
Yeah, yeah. I made a note already.
Okay. Next case 10. Guys, I'm sorry, but I will have to leave you.
Okay.
I'm not able to stay longer just today. I have to go. Sorry.
All right, all right. Komal, what do you say? Shall we meet tomorrow?
Sorry?
What do you say? Shall we meet tomorrow now?
I didn't say that.
Okay. All right, all right. So we can continue. That's all right.
So you guys can continue. Let me go. See you guys later.
Yeah.
So
Okay.
tomorrow you don't know how much you're going to have for today.
8:30 p.m. Yeah, tomorrow. See you then. Bye bye.
8:30 p.m.
Yeah.
All
Bye
right.
bye. Bye bye.
Tomorrow 8:30 EST. Yeah. Tomorrow 8:30 Melbourne Sydney. Okay. Bye.
Yeah. Bye bye.
Bye. Bye.
Okay. So next question. So this X-ray question, I'll put it there now. Okay. Case 10.
Patient. Okay. The physio wants to check his exercise tolerance. What is the appropriate measure for it? I would go for what? 1.
Yep. Definitely 1. We've discussed this before. We have discussed this before.
Question. After assessing his exercise tolerance, the physio gave walking program to be effective. How long does he have to walk per day?
30 minutes. Answer is D.
Yes. This is the repeated one?
Oh yeah, it is repeated.
Yes. And the reference is ACSM? No, it's pulmonary tool. It's pulmonary toolkit? Yes, I got it. So it's 30 minutes walk, right? Okay. Yes, it's given 30 minutes for all. Level walking, treadmill, everything. It's mentioned 30 minutes. Okay. How many days per week walking is effective?
3 to 5 times. So option 1.
It is 3 to 4. So we can get 4 to 5.
Yeah, we can do 4 to 5. Yeah, correct. So, but correct. It would be better to have a B. Correct.
That is 3 to 5, right?
It is 3 to 5. Yes.
5. We can go for 3.
But why wouldn't we go for option 1? Because it's also between 3 and 5.
But it's 3 and 4.
It's 3 and 4.
Yep.
So small gone to 5. So 4 to 5.
Okay. Okay.
Patient
and gained exercise tolerance, and he wanted to continue it with physio. Continue it. What physio will advise him? Stop walking, continue walk for 3 times per week, join gym, or decrease exercise to 2 to 3 times a week. It's the same what we cardio recall we did it.
Yep, it's B. Okay, the next one is also same. It's the post hemicolectomy, the ABG normal, blah blah blah, and what are the risk factors for this patient? It's age, COPD, opioids, and malignancy. So we were again between this, right? Whether it's opioids or whether it's COPD. Yeah.
Yes.
Maybe it's opioids because they mentioned patient is drowsy. So one of the side effects of opioids is drowsiness. So maybe opioids.
Yeah. It could be opioid, very highly.
Yeah, and nobody has here they have not mentioned about that bilateral bilaser infiltration.
So it's most probably opioid.
Yeah. The doctor told to do suction for the patient. What will the physio do? I'm not sure.
I think if the doctor is asking to do the suction, it should be oropharyngeal.
Oropharyngeal, yeah. Guys, no, nasopharyngeal. Nasopharyngeal is well tolerated than oropharyngeal.
No, but you see, majority of the cases we will do oropharyngeal. We'll only do nasopharyngeal if they have a very strong gag reflex. But majority cases we always start with naso.
Yeah, but if you go by reference of file, they say nasopharyngeal is well tolerated than oropharyngeal.
Yes, it is definitely better tolerated because there could be some patients, but just mark my words, some patients who will have a very high gastroesophageal reflex. So for them, we will not we won't do for that case we will prefer them to do a nasopharyngeal.
So nasopharyngeal, I feel a nasopharyngeal is best tolerated than oropharyngeal, so we would definitely go with nasopharyngeal.
Well, I mean,
I agree with nasopharyngeal.
Okay, all right.
Sorry, I would agree with nasopharyngeal because you can stay in there for longer. It doesn't really affect their breathing as it's more comfortable. And one of the contraindications would be if they have got some form of head injury, but we don't know anything about that.
Yep.
So, and it doesn't set off the reflex. I don't know how it's called if you do nasal. So I would definitely do nasal.
Right. Okay. All right.
Sorry.
We can actually ask this question because in my opinion, it should have been oropharyngeal.
Guys, can you just put this because I'm sure it was mostly nasopharyngeal.
Okay. All right. I'll put it there.
That is given in crop file actually.
अच्छा ठीक है. I will put it there.
How would you know the patient is independent in their exercise and can have ability of patient to use PCA?
Could you put the question up, please?
Yeah.
Thank you.
No problem.
How would a physio know a patient is independent in an exercise? Can ability of patient to use PCA? Oh my God. Use of PCA for pain control before moving the wound. Dosage of PCA and frequency of usage of PCA.
Frequency.
Yeah, it's C.
with that. But I think the frequency is the important one, because if they're not sure, they just press and press and press,
Yes, frequency
and
is
don't
more
get
important.
anything. Pardon?
Yes.
I think it's...
Yeah. It's the same question again, the age, opioids, metastasis. We can do a PhD on the question itself. Yeah, it's opioids.
Yeah. Maybe, yeah, morphine can reduce the respiratory drive.
Okay, I'm just putting the Mr. A wala question. Hang on, huh?
No, don't put that. It's the same one.
Oh, it's the same one? Okay. Oh, yeah, it's the first question. You're right.
Same, don't put it.
How his wife would be part of the rehab, that's also that she will encourage him. And then Mr. A now feels better that he's able to walk 500 meters. So,
One new question. How self-monitor his exercise?
ah,
We did that?
no, we did not.
Oh, last question.
Yeah. Level of exertion.
Yes. No, not level of exertion, it's walk speed.
Oh, it's
No, I spoke the level of exertion.
But the level of exertion, you have to some reference. How you judge the level of exertion? The box scale will guide it. So what is your level of exertion?
You cannot self-monitor the box scale, can you?
I read somewhere, but I forgot to mention the reference.
Yeah, I think we can't self-monitor the box scale, no? Because how he would know that it's at 4 or it's at 8? But he can tell by the perceived exertion, that, okay, I'm feeling exerted, so I need to stop.
I'll find it. If I'll get it, I will tell you tomorrow.
Okay, that would be great. Or, even he can monitor his respiratory rate. That's not too difficult, I think so.
But it is not given anywhere.
It's not given
Better
anywhere.
to go with the level of exertion.
Okay.
I can't see the question.
Guys, is it given in pulmonary toolkit?
No, I think I read somewhere prior.
Oh my god. Okay, case 5.
Toby.
This question had came yesterday.
Oh, really?
Yes. You are asking about what is Toby?
Oh, yeah. That's it.
Yes.
Toby Empaima.
Yes, Toby.
To be 2 years with drained empyema in left upper lobe, was in ICU for 10 days. Shifted towards drains not in place anymore, but still have RV in situ. Afraid of medical personnel, especially the physiotherapists, and even don't speak to them. How to assess his chest?
In his mother's arms. D.
Everybody agrees to this?
Yes.
Okay. Next, how to increase his ventilation, blow bubbles and make burst them. Tell him to lift his hand up and down. Tell him to lift his hand up on the inspiration and bring his hand down on expiration.
A.
He's a kid, guys.
Yeah, he will not do the exercise. So
He's just 2 years old.
Yeah,
So
of
we
course.
need to check his compliance also.
Yep, that's true.
already afraid of physiotherapy.
Okay. How to make him walk to improve his condition? What advice physio gave his parents regarding his health? Ask the patient to hold his hand and walk him to the door. Ask the parent to stand at the door and call out to Toby. Ask the patient to hold the drains while you walk Toby. He is very weak, so to support him, hold Toby at hips. I hate this Toby question. No, it's because even the moderator had so many different views with this.
Right.
They had removed the drains, I thought.
Yes, they had removed the drain.
So he doesn't need to carry drains.
But he's got IV drains.
Oh, okay. So he's got a stand, possibly.
Guys, this is I'm sure put it on Facebook. People will answer because they must have written it yesterday.
Okay, sure. I can put it there.
I think the only way to motivate him is for his parents to call him.
Yeah, second one, B1.
Yeah. I'm a pediatric physio. That's what I would do.
Okay.
Okay.
Guys, there was the same question in APTA group. Okay. And okay, can I post that question?
Okay.
And what did the moderator say about the question? Okay, I'll just post it, guys. For y'all, so y'all can have a look, read it. That is what the moderator said. Yes, sorry. Okay.
Okay. So if Toby was 10, we would still get him to stand, check strength, etc. first. Get clinical staff to help to carry drains. If not present, then use family member if they understand. We can do more hands-on compared to Toby who is 2. So we can do more hands-on. Okay.
But then he's very scared, isn't he?
Yeah.
Yes,
He lets
very.
us.
So question third is not an option because Toby won't walk with you. So he will scream and make him run away. It won't.
Yeah.
Guys, this is the answer. This is the answer for what I have posted about the question.
Yes,
See,
yes, yes.
the options are different.
Okay.
So I'm just giving you an idea. This is what the moderator has said.
Right. But moderator says that the option 1 sounds like a good option, but we need to know how good his standing is, and do we may need support. Yeah, so mother can do it.
Yeah. So if you see that in this the above question, first one is instruct the mother to get him up to standing, supporting him with her hands because he will be very weak from bed rest. So what we want them to do is make him stand. Okay, so we can assess the standing balance, and then if the physiotherapist feel that he is okay with the standing balance, and then go with the walking thing.
Right.
So according to that, for our question, the first one should be more appropriate.
Yeah. A seems to be appropriate.
Because cannot leave the child alone and call him.
Yep.
Because he'll cry more.
Yeah.
Cry more, or don't know about the status about.
Yeah, I would go with one because if the parent is standing at the door and call out for Toby, I think he would be reluctant to be with us because he's afraid of medical personnel. And ask the parent to hold the drains, I don't think so. It's a job of a physio assistant, so cannot be.
Yep.
So one is the answer.
I think one, yeah, suits you the best.
Yeah.
Okay. How physio will position him after the treatment finishes?
High supported sitting.
One.
1.
Guys, are you sure about this?
Don't have reference. Last time also we discussed the same.
It's not immediately post-op or it's not immediately so I'm not sure about this. I could give even sitting out of the bed.
Yep. You're right, Komal.
I would give even sitting to the side of the bed. I'm not sure.
Last time also we have the same condition. You know that the
No,
that is for assessment. The question is for assessment. How will you assess?
yeah, I think immediately post-op we can put the patient into high supporting, but I'm not sure when the drains and everything are removed how we can. We need to study more on this. This Toby is always a problem with all the groups.
Toby and Paima. You know, for a second I thought I asked I asked Tulsi, I've never heard about Toby and Paima. What's that? And she tells me, oh, no, Toby's the name of the patient. It's not a condition. I would have thought that it's not sitting out of bed or sitting at the side of the bed, because I think it's quite important to leave the patient in a supported position, comfortable position. That's why I was thinking of going with A.
Okay.
And you know, before he was refusing to walk with us.
Yep.
Like it's not a comfortable position to leave him in a sitting out of the bed. That's why. And he's a child. That's why I put him back to the high supported. If it's like a adult person, then I can put them in sitting out of the bed position, but not child.
Yep. Yeah, I agree. Yeah.
I only would sit him out of the bed if he would be sitting on his mum's lap. But if not, then out of experience, they somehow feel quite safe on their big bed. So high supported sitting.
I agree with you actually. And yes.
Yeah.
Still can put it on Facebook.
Okay.
Guys, can we put this as last case? I think for today, or we need to.
Oh yeah. Please, let's keep it as last case, because I'm thinking that are we going to finish all the 32 pages, because we are already at 17, or just at 17, just halfway only.
But almost all the questions are repeated.
Right.
Okay. So what we're going to do tomorrow? Same thing. The continuation.
What do you say, Komal? Shall we finish the continuation? Do the continuation?
Yes.
Yes, we will do the continuation. variation. If the question is repeated, we will, if the question will read it fast and just verify the answer, and we will go for, if the time is there, we'll go for the next question.
Sounds good.
Number.
Sounds good. Sounds good.
Guys, all the questions are repeated.
Is it? The rest
Yeah.
are all repeated? Okay.
Oh yes, it's repeated one.
Let's do the last scenario, then just check it out. If any new question, we'll do it. Otherwise, we'll complete with this.
Yeah, because you see the case 7 that I'm seeing over here, the second question out of there, what side effects can we expect from oxycodone? I don't think I've read this anywhere.
Guys, oxycodone is the answer is dryness of
Yes,
mouth.
dryness of the mouth.
Okay.
Where would you go to find the information about all the medications that we need to know?
Profile?
I don't really know what medication or about what type of medications I need to know about, and I don't know where to look to be able to learn it.
Oxycodone is there.
Oxycodone is there in profile, no?
Opioid.
Is it there in profile?
I read when
Trial.
and he uploaded a thing last time. You know that surgical.
Maybe I
He uploaded something on independent learning package of surgical things. And last session.
It's ILP, right? ILP book.
Yes, I'll see. In this it is mentioned.
Oh, in that it's mentioned, right? Okay.
Yes.
I think it's there in profile also.
Yeah, it's proponent trial.
Leona, you were talking something about where are we reading the medications, right? So far, I don't know, actually. And any of you, any ideas where you are reading the medications from? Anything? Pharmacy stuff? Or just reading it as they are coming?
Just reading it as it's coming.
Yes, same here. So if I'm finding something about like oxycodone and all, then I'll just go and review a little bit about it.
Is there one of us who's, I don't know, a physio assistant or so in hospital and could put a list together of the things that they come across mainly?
I don't know
Have
if
you got anything like that
I don't think
anywhere?
any of us is a physio assistant over here.
No,
I'm a physio assistant actually.
Oh, you are
Oh,
working. Okay.
Yeah, but I'm not working in a hospital actually. I'm working in aged care.
I
So
see.
we don't have any like list of medication which we go through actually because so we don't need to worry
Where
about.
are you working? Where are you working?
I'm working in aged care in Wembley. In Perth. Yeah.
In where? Sorry.
In Wembley, in Perth.
Oh, which age care are you working for?
My aged care name is Kohinoor.
Oh, okay.
And we can get directly to assistant job.
Yeah, we can get directly to the assistant job because I applied for 3 years and they will keep on saying that you are overqualified for this position.
Oh.
But then after I was lucky that one of the senior physiotherapists, she was born and brought up in Singapore, but she's Indian and she believed in Indian degree.
Okay.
That's good.
Yes, like she believes in she rather appoint a bachelor of physio than the the physio assistant, the certificate course one.
Yes, I think it is better.
Yeah, that's why she appointed me.
Okay, that's good. That's good.
Well, I try to find, I know a physiotherapy student. I try to find out from her what kind of medication they need to know about. And then maybe I can post it.
Yeah. It's a good idea. Even I can ask my senior physiotherapist that she's working in hospital, so I'll ask her.
Yeah, that might be really good.
Yeah. She have like 25 years experience, so she know about it definitely.
Yeah. Great. Also, are we going to speak about asthma and bronchiectasis tonight or not?
I think my brain is too mush for anything else.
Same here.
Mine's the same. I haven't eaten anything either. I'm starving.
Oh dear. Okay, you should eat something. You should grab something. So I
Yeah,
think.
it's fine. It's fine. Don't worry.
What do you guys think? Shall we keep it for tomorrow?
Yes, we will keep it for tomorrow. We'll see what are the same question. We will not discuss the same question. If the question is different, we'll discuss only that question.
Sounds good.
2-3 questions are there which are different. So we'll discuss that and we'll switch on to the next December June questions, right?
Okay. What I'm thinking is that maybe we don't start the new thing tomorrow. We can finish this question paper and then we can have our topics which we are wanting to discuss, because it will also set a foundation for us. Okay.
So discussing
We discuss the topic first
I'm sorry.
and then questions. Should we discuss the topics first tomorrow and then the questions?
Yeah, we could do that also. We could do that also, because then we are in a fresh mind. Yeah, we could do that. We could do that.
By that time we are all trained. Yeah.
Yep. Sounds good. We could do that.
And should we do it like
In the recalls, in the questions. So we are planning to do asthma and bronchiectasis discussion, and then the rest of the questions what's left from today we'll finish it tomorrow.
So the discussion is like just knowledge about that topic, or just how you go with the discussion.
Yeah, we are going to try it for the first time tomorrow. So we if anybody has any questions about those topics, then bring it up, or we'll share our knowledge, whatever we have.
Discussing cystic fibrosis as well.
Sorry. No, not cystic fibrosis tomorrow. Asthma and bronchiectasis.
Alright, as earlier it was written on the FT
Yes.
that we're discussing cystic fibrosis as well.
Also. Yeah. I mean, I think it will be too much for tomorrow. Indeed.
Yeah, it's fine. Yeah.
Tomorrow.
That's alright.
Cool.
I mean, if we would maybe kind of give different parts of the condition, I don't know, symptoms and or causes and symptoms, and then treatment and I don't know.
Contraindication.
Yeah, something like that. So then that's manageable for each one of us, instead of having to revise everything.
Yeah.
No, but I think we have to read everything, because if we stick to one area, we will read that only. We have to read everything.
Yeah, no, I was thinking that we kind of present it to the others.
yeah,
Or maybe,
because that's how we will speak now. Everybody together. So we'll read everything, but then if we assign,
Yeah, if someone can speak up for indication or like treatment, and then someone can go through the contraindication and treatment and all that.
Yep. I think that's a good idea. So everybody reads everything, but then tomorrow we can split, like who's doing the introduction, who's doing pathophysiology, who's doing the clinical features and X-rays. Yeah.
Yeah, that's the best idea.
That's the best idea.
Yeah, or I think tonight only what I think I will sit with Tulsi and I will ask her how we divide it. So, at least that person knows what they're going to talk about tomorrow.
Okay.
Yeah, so I think me and Tulsi can put it later.
No,
Hun-
we can include all, or we have to just include this present 7 people are there now.
Yeah, okay. Then I'm okay with anything, because the thing is that I was thinking at least if everybody's gone later, then it's very hard to catch them. So, let's say the topics for asthma. Do it now. Okay, fine. I'm trying to run away since so long. at least for 1 hour, I'm trying to say stop. Okay, never mind. Asthma topics for discussion. So we have.
Sorry, all the questions are repeated for after this. All the questions are repeated. I don't think so. There's a single question which we have not. One question is there. I got it.
Introduction.
That what would I do therapist record in handover notes?
Yeah.
I got two quick questions.
Clinical features. X-ray. Medical.
And one question is that how would you modify your assessment for this patient? We did this question, but the options are different.
Medical management, and what else is there? PT management.
Guys, I need to leave. I'll be seeing you all tomorrow.
Okay.
Just choose your topic and go.
I'm okay with anything. I'm okay with anything. Just let me know what topic I have to prepare. I'll do that. No problem.
All right. Okay.
Shall I do pathophysiology?
Yes, please.
Introduction, maybe?
Okay. You're doing the.
I can do clinical features
Okay.
and X-rays if I can do explain.
Okay, both of them. You're doing both of them, clinical and X-ray. Fine. So, Leona is doing. Yeah, correct. Adult and children, correct. So, introduction and pathophysiology, Leona is doing correct.
Yeah.
And clinical features and X-ray, Heli is doing correct.
Yeah.
Okay, then we are left with medical management and physiotherapy management. Jaspreet, you want to do anything?
Yeah, you can give me any one of
No,
that.
no, you choose.
Yeah, no problem. You can give me any of that.
Okay, so medical management, do you want to do medical management?
No problem. I will do it.
Komal, want to do physiotherapy management?
I wouldn't prefer that.
You don't prefer, is it? Okay, then we have bronchiectasis also, right? So
Yeah,
you,
I can do that.
okay, PT management, who's doing then? Or asthma? Okay, Renuka, perfect. Then Komal, you want to do anything from bronchiectasis?
Yeah, I'll do that. No problem.
Okay, which ones would you do? The same similar topics.
Yeah, I'll try to cover introduction, patho, clinical features, X-ray, whatever is okay.
Okay, then maybe clinical features and X-ray?
Yeah, perfect.
Bronchiectasis, perfect. Okay, that's great. All right. Tulsi, you want to do anything?
Yes, introduction and pathology of bronchiectasis is there, no?
Yeah. Okay.
So I'll do that introduction and pathophysiology of bronchiectasis.
Okay. In out of us six, we have already got our topics right, except for me. So I think I will go with medical management for bronchiectasis. Okay. And then we are left with PT management. So we can ask Martha to do it. All right.
Okay.
Yeah. Okay. So I'll just put the topics over here. So just stay with me. Can you hang on with me for a second?
Yes, sure.
So that I don't get the topics wrong, okay? So, introduction of asthma. First, I'm writing the asthma topics. Introduction and pathophysiology is Leona.
Clinical features and X-ray is doing Heli.
Hmm.
And do we do kids and adults together or not?
Yes.
Yeah,
Kids and
okay.
adults together.
And I can use the prayer and prasad, yeah?
Yes. Yeah.
Okay.
If you have, you can use half also.
Peds
I
and
don't have
adults.
that.
I haven't got I've got prayer and Weber at the moment. And how. And asthma stuff, books. Will you be happy with that?
Yeah, I think that's pretty good. And then I think you can also make use of ILP, Helisha.
What?
ILP. I'll post it to you later.
Thank you.
Sure. Clinical features
Yeah, great
and
job.
thank you.
What is ILP?
It has some very good information. I'll post to you also, Tulsi. X-ray
Also to
also.
all of us.
Yeah, sure. X-ray and clinical features, Helisha. Then medical management and PT is by one person, right?
Actually, I will direct you to the estimate and the estimate side.
I'm sorry?
No?
Medical and PT management. Okay, so that's the topics for asthma. Have a look. I hope it's the correct thing, right? Okay. Introduction and pathophysiology was Tulsi, correct?
Yes.
In regards to X-rays, I'm a bit dusty at the moment. To just go back to everything that you see on a normal X-ray, so you then can compare it with one with some form of pathology. Where would you look for that? Is there anything on YouTube anybody is aware of?
A lot of information.
Website?
Yes. YouTube you can get some information. Intro
Okay, so just put in normal X-ray
Yeah.
or something.
Yeah.
Okay.
Put asthma X-ray.
Asthma X-ray.
Yeah.
Okay.
Clinical
I'll try that.
features and X-ray was this one, right? Komal. And what else was left? Medical management was me, right?
Maybe.
Yeah, it was me. And then PT management was Martha. Okay. Sounds good.
And are we going to type information so when we finish, everything can be collated so each one has everything?
You know what I think is that if I mean it would be nice if we can make put a little effort to make this right. So do you think it's a good idea if we can make a PowerPoint presentation?
Yeah.
Yeah, because it won't be more than 4 slides. It will be just 4 or 5 slides, right? It won't be more than that. So you just put the highlights over there. For example, like if you're talking about X-ray of bronchiectasis, there is not much you can see in the X-ray. There would be more actually you will see in the CT scan. That's the investigation bit, you know. So something like that. Just put the highlights. It will be great.
So just. So could I say with the pathophysiology, would you do the clinic examination as well? So I don't know, spirometry and all those things? Or
No.
would there be clinical features or?
So no. So your topic is introduction and pathophysiology, right? So pathophysiology, you'll be talking about asthma. There is hypersecretion and there's goblet cell production. There is edema seen. So that would be the pathophysiology. Clinical features would be what this guy is showing. Like he's got a lot of cough, and he's got night cough, things like that. Yeah. That would be Heli Shah.
Yeah. And kind of asthma action plan and stuff?
Yeah, so the management, this medical and the physiotherapy management Renuka is talking. Yeah. It's a big topic, Renuka. Medical management and PT management.
I divided medical management for Jaspreet and PT management for Renuka.
Oh, Jaspreet doesn't have a topic?
Yeah, that's what I was thinking.
Oh, sorry. You don't have a topic? Oh dear. Okay, so between Renuka and Jaspreet, who would like to do medical and who would do the PT management?
You both decide.
on the Asthma Foundation website about medicates.
Yeah,
Treatment stuff.
yeah. I'll share a file with you so you can actually get some information about the anticholinergic or beta agonist drugs and all that stuff. You need to who's doing the medical management. It's more like you'll have to get information about bronchodilators and beta agonist short term and long term ones. I'll post you something so you can actually have that as your base and you can work from there. What do you think?
Sound good.
Okay. So do you want to do medical or do you want to do physical therapy management?
Medical management.
Okay, Renuka, then you'll do the PT management?
Yep.
Okay, cool. I'll just retype this bit. And I think, yeah, then we can, we're pretty good with this then. Then we can meet tomorrow.
Okay.
Cool. See you.
Nice talking to you all.
Yeah, see you all.
So it's Australia 8:30, yeah? Sorry. Sydney 8:30 time, yeah?
Yeah.
Okay.
Yeah. Okay, cool. See you then. See you. Bye-bye.
Bye-bye. Take care.
Take care.
Bye, everybody.
Bye-bye.